Hey everyone, my name is Allie Nelson and I am a physical therapist and I work in a clinic south of Denver. I am currently an orthopedic resident of Upstream Rehab Institute and I'm going to be talking a little bit about patellar dislocations. So first I want to talk about immobilization. There's a variety of factors that go into this. First I want to talk about how long a patient should be immobilized. The Chronister protocol specifically will only immobilize for 24 hours. I've seen that some will go up to also about 4 weeks, and some will depend on how long it takes for the quad to be functional again. The position of immobilization will vary. I've seen the Chronister protocol, that I will also link below, will immobilize in 120 degrees of knee flexion. However, the most common is about 20 to 30 degrees of knee flexion. And I've also seen full knee extension. Most will say that full knee extension is what is most functional. However, when a patient is in full knee extension, the only restraint is the soft tissue, and the MPFL is actually in the most elongated position. Having about 20 to 30 degrees of knee flexion actually assists with having the patella in the trochlear groove. The Chronister protocol also talks about how short-term immobilization is actually better for the patient due to a variety of factors. First being hemarthrosis, which could be painful, limit range of motion, and it could develop adhesions. The prolonged immobilization also will refer to muscle atrophy and will actually take a lot longer for a patient to recover if they are immobilized in a long period of time. Next, I want to focus briefly a little bit about what rehab will focus on. First, a lot of therapists will start with quad strengthening. The quadriceps is what helps with the patellofemoral tracking. Basically, what we're looking for is we want to make sure the patella is actually tracking appropriately in the trochlear groove. What happens commonly is that lateral subluxation when there is abnormal tracking of the patella. So focusing on quad sets first is very important. Then, it's important to look at adductor strengthening. So as we know, we can't isolate the VMO, but we can work on strengthening the adductors. Keeping the adductors strong is what helps in terms of keeping that patella from tracking laterally. If our lateral structures are tight, then it's going to continue to track laterally, so we want to make sure we strengthen the medial structures, so again, our patella is tracking appropriately. Next, it's important to look at the hips. Do not forget to look at this. I will personally say that this is one of the faults that I had when I was first treating my patient. So if you think of this, many adolescents have impaired proper biomechanics when it comes to squatting. What you will see is hip and knee valgus adduction internal rotation. So basically they dive in whenever they go into a squat. Why does this happen? We all know, if we had to think about it, it's because of glute med weakness and hip abductor weakness in general. So it's important that we also focus a little bit on hip strengthening, as that will also help in terms of having the proper biomechanics, but then also helping them when they return to that functional sport. Following that, the fourth thing will be proprioception. So the MPFL is actually innervated. So depending on if the patient had surgery or not, we still want to make sure they're getting that proprioceptive input. If you think about how much dynamic stability an athlete needs, this is super important to get back. Then it's also important to continuing that proprioception area is to look at core control. So if we have decreased core control, then we're also going to have compensation within the hips and the knees, and it could go down to the ankles as well. So making sure that they have a functional core is super important. Once we have accomplished all that, then we can get into what is the fun part, which is that advanced strengthening phase. So we want to make sure that the VMO and the vastus lateralis have an appropriate ratio. So like I talked about, the outside structures can get really tight, causing the patella to track outside and laterally. So we want to make sure that our medial structures are really strong before we progress to this phase. With this, we can get into squatting, we can get into lunging, and there's actually evidence that shows that to actually strengthen the VMO in about 60 degrees of knee flexion in closed kinetic chain will help with assist in strengthening this. So adding a ball, doing anything in adduction will help with this. Then we get into the fun part. So all the plyometrics, we can add hopping, we can add squatting, we can do box jumps, we can do lateral stuff, anything to get into that multi-directional movement. However, like I talked about, it's important to have that hip control. So we don't want to progress a patient too fast if we're noticing that they have impaired biomechanics. So we want to make sure that we're progressing them appropriately. Then lastly, my second, probably fave, is to get into the sports stuff. So looking at what our athlete is returning to, whether it's a team sport and they need to do high agility, that multi-directional, that lateral shuffling, jumping, or is it looking into how they're landing? So if it's a gymnast, personally, then I'm looking at how they're landing, how their squatting biomechanics are when they take off, as well as soon as they do whichever move they need to in the air, and then how they're landing out of that, or landing off a beam, or doing any type of activities. It's looking at that. So adding in different activities that include how looking at the proper landing biomechanics is super important. It's also important to look at single leg stance. So not only how the athlete is landing, but like my gymnast, she does a lot of beam work. So looking at how her single leg stance, is she having still the proper biomechanics, but still on that leg that she subluxed in? So can she be able to perform turns? Can she be able to perform all the twists and turns that she needs to do to be able to perform her beam, her floor routine, and whether it's bars, looking at all of that as a whole. So it's very important to look at everything, but also break it down and make sure you're progressing them appropriately. So once we start thinking that our athlete is ready to return to sport, there's actually a criteria that will help us to guide us in our decision making. First, we're going to make sure there's an absence of pain. Second, making sure there's no joint effusion. Third, they have full range of motion. Fourth, that they have almost symmetrical strength, meaning they have at least 85 to 90% strength on the uninvolved side as they do compared to the involved side. And then lastly, we want to make sure that they have good dynamic stability. However, it is important to consider this could take anywhere between 6 weeks up to 6 months. So it's important that we're progressing our patient appropriately. Next, it's looking at how we can test them. The single leg squat and the STAR excursion balance test will look at dynamic stability. The drop jump test will look at symmetry and their alignment when they are landing. And then the side hop test will look at speed, agility, and coordination. For all of this to be successful, we want to make sure this implies there's no early re-injury, there's no further damage to the knee, they're returning to at least pre-injury level or better, they're not limited by pain, and they are playing at the same level within at least 5 years. So should your patient have surgery? Generally, if they're a first-time dislocator, they will benefit from rehab. However, if this is their second time or multiple times dislocating, they will benefit from surgery. In surgery, they will go in and they will actually tighten the MPFL and release the lateral structures. However, when comparing non-operative groups to operative groups, they have similar results in terms of instability, but when looking at likelihood to redislocate, the operative group had about a 10% decrease in likelihood that they were going to redislocate. But when comparing functional outcome measures, the non-operative group had improvements overall in quality of life and overall patient satisfaction. When considering if a patient is a good candidate for surgery, it's important to look at if they are an adolescent. If they are, it's important to look at the age of them and their growth plates. So if a patient has severe trochlear dysplasia, meaning that there's abnormalities in how the trochlear groove and the patella are functioning, then they will go in and they will actually make the trochlear groove appropriate positioning for the patella to fit appropriately. Sometimes a common thing is that they will have a shallow trochlear groove, which will predispose them to tracking laterally just due to their anatomical position, which predisposes them to subluxing or dislocating. So they will generally do this if a patient is expected to stop growing within at least 2 years. However, it's important to look at the patient as a whole, looking at what they're trying to get back to and the likelihood of them redislocating when considering this. I really hoped all of that helped. I actually have a blog linked to this as well. This is just a little snippet that I put in my blog, but basically I chose this topic because I've actually seen a decent amount of patellar dislocations. And I have to say, just in general, as a physical therapist, one of the hardest decisions to make is returning an athlete back to sport. It gets to be really scary because of the fact that you can rehab them as much as you want, you can challenge them as much as you want, but it gets down to the point of assimilating those activities and what they can tolerate and getting them back into practice and knowing in your gut that you've done everything that you can, and that they can tolerate what they're doing in practice, and then not knowing the other stuff that they're also doing. Like you can get a glimpse of what they say they were doing in practice, but then they could be doing extra stuff that they didn't think was important. So it's really knowing what they can tolerate, returning them to full practice, but also keeping in mind of your own head, so to speak, in terms of like when they have nationals, when they have competitions, like really understand and trust your knowledge and trust your gut in how you're progressing them. Because I will say it is one of the hardest things when they say, I want to be able to compete in this competition within a month, and they just recently dislocated their patella. They can't get their full range of motion. They don't have the strength. They're not progressing on how you should. Like, do they need surgery? There's all these other confounding factors that go into your head, and it's hard to know, like, am I progressing them? Am I doing everything that I possibly can? So I really wanted to dive in and look at this and being able to know that what I'm doing for my patients is appropriate. And, if it means that they can't compete now, it could help them, because then they could just be a stronger competitor next year if that's what it takes. So I really hope this helps shed some light to other PTs and to help others understand. And I hope you guys enjoyed.